Hello everybody, it's the last day of San Antonio Breast Cancer Symposium and we are very happy to have two amazing guests today. I'm with Cash and Paolo and we will tell you what is the highlight and perhaps practice change for Monday. Thanks Cash, thanks Paolo to be here with us. So Cash, what's the highlight today for the last day?
Thanks, Jamil. So I think we had some very exciting data today. There was a late-breaking abstract which made it to the formal presentation, which was the INAVO 120 study. This is the study looking at the novel molecule inavolisib, which is a PIK3CA inhibitor. It's a new generation inhibitor, and it's much more selective and has a much better toxicity profile. And this was a phase 3 randomized study looking at first-line treatment of patients with endocrine refractory disease, metastatic first line, randomized to either receiving fulvestrant plus palbociclib or fulvestrant plus palbociclib and inavolisib in a randomized fashion. And the results were actually quite impressive. So we saw that in this first interim analysis with about 20-month follow-up that we had a doubling of the PFS, which was statistically significant. So we went from about 7 months to 15 months PFS in the first line in these patients who are classically very refractory to endocrine treatments from the get-go. So the hazard ratio was 0.4, again, quite impressive. We even had a preliminary statistically significant overall survival benefit already, like this first interim analysis, which was also exciting. And what's even also very important is the toxicity profile, because we know that with these PIK3CA inhibitors, classically we have some drug-specific toxicities which could be problematic for the patients. So I'm thinking hyperglycemia, I'm thinking diarrhea, I'm thinking rash, and sometimes these are very drastic and leads to the stop of therapy. So with the first generation drugs like alpelisib, this could happen up to 33% in a grade 3 fashion in the study population. However, with this new generation of the drug, we're only looking at 5 to 6% grade 3 toxicity, such as hyperglycemia, and only about 6% dropout rate, which is extremely exciting to see that we have a new molecule that's not only efficacious, but also very tolerable and with good toxicity profile. So in my opinion, this is probably going to be practice changing in the future, and it's exciting to have one more additional therapy in our arsenal.
Very nice, very nice.
Yeah. So Paolo, what do you think of this data? Are you guys excited?
I'm extremely excited. I think, first of all, it's always important to have additional drugs in our arsenal. Mm-hmm. And so we were stuck with having one drug targeting PIK3CA, that was alpelisib, but now recently we've seen the approval of capivasertib, and now this data with inavolisib. And it's, as you mentioned, it's so important to see that the rate of high-grade hyperglycemia was much lower. The rate of discontinuations was also low. We still have certain toxicities, and so we still have work to do. And I'm also excited about many mutant-specific PIK3CA inhibitors that are being tested, but in general I think it's just a path, and so we are moving step by step, and this is an important step for a population with an important unmet need, because we've seen that PFS in the control arm was only 7 months, so we really needed something better, and I'm very glad that we did find something better in this trial.
I agree with you. So what was exciting for you in this today's
So I'm more of an ADC guy, and there were many interesting ADC abstracts and presentations presented. One that I was very glad to see was an update of the Catherine trial of post-neoadjuvant TDM1 as a rescue strategy for patients with residual disease. And after long-term follow-up, there was a 15% delta in IDFS and significant overall survival advantage. So really telling us that by escalating treatment in a post-neoadjuvant setting, we can improve outcomes for our patients. And I'm really looking forward to additional escalation trials like Destiny Breast 05 with TDXD, or also with the addition of tucatinib in CompassAir RD and other trials ongoing, also Stefania with atezolizumab. And then it was interesting also to see the HER2 CLIMB-02 data with the addition of tucatinib to TDM1 in a metastatic setting for HER2 positive metastatic breast cancer, significant PFS advantage with the addition of TDM1. We still have to follow this data to see if overall survival is also improved. That is extremely important, of course, and there were some toxicities, as we may expect, in particular liver enzyme increase, but in general it was a manageable combo, and I'm looking forward to see more in the future with this combo.
And how do you think we're going to sequence this combination? Because classically I use tucatinib plus Xeloda after TDXD failure. Do you think that's going to be an alternative to that? We're going to use it in a different sequence?
Well, it's extremely important question, and I do believe that right now we don't have a good answer, meaning that we don't know if we can use two different regimens that include tucatinib with a benefit. And so for the moment, in case it was approved as a combo, I would consider it as an alternative in case I did not want to use chemotherapy, but instead I wanted to use a selective chemotherapy like TDM1 that usually is well tolerated, has got a favorable administration once every 3 weeks instead of having oral pills every day. But we do need to do the trial. We need to do a trial of sequencing, a trial that tests if there is a benefit of continuing tucatinib, and I think there may be a role for that, because we know that continuing trastuzumab beyond progression is advantageous, and I think also doing the same with a TKI potentially could lead to an advantage.
Paolo, I have a question for the residual disease that many oncologists ask. You know, when you receive neoadjuvant treatment and you have HER2, you would give TDM1 to everyone, even if you have 0.1 millimeters with lymph nodes negative, 3 positive, or there's some patient that you don't give TDM1 and you continue trastuzumab. What is the residual disease? What is your trade-off when you start TDM1?
Extremely important question, because it happens quite often that you have very minimal invasive disease, and I have to say in the trial patients with minimal invasive disease were included and they derived a benefit. So yes, for me the boundary is any amount of invasive disease left. Of course it has to be invasive disease, not DCIS, but in general, since we have this major benefit, I think for any patient with residual disease it's a good practice to include TDM1 in the neoadjuvant setting. One question that remains open is that in the population of patients with HER2 2+ amplified, there seems to be a slight lower benefit compared to 3+.
Yeah.
I still think we should use a drug, but it's something we should test and understand, because novel ADCs potentially may have a role there, because they can overcome heterogeneity with the bystander effect. But for the moment, TDM1 is what we have. It has a major advantage also in overall survival by 5%, and I'm very glad to see these results today.
Even in the subpopulation of 3 positive breast cancer?
Yes, in all of the population of positive, and even among those patients that lose their 2 positivity after neoadjuvant treatment. That happens quite often.
Yeah.
Even in those patients, in the sub-analysis, there seems to be a benefit, and so we should use TDM1 even if residual disease is negative, if the tumor was HER2 positive in the beginning.
Thank you, Paolo. Thank you, Cash. See you soon. Bye-bye.
See you soon.
Take care.